From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to our listeners around the world to this JAMA Author Interviews podcast. I'm your host, Dr. Greg Marcus, Associate Editor at JAMA and a cardiac electrophysiologist and professor of medicine at UCSF. I'm here with Jonathan Kim, Director of Sports Cardiology and Associate Professor of Medicine at Emory University, and Aaron Baggish, Chief of Sports Cardiology, Professor of Medicine at the University of Lausanne in Switzerland. They have co-authored an original research paper in this issue of JAMA with a simultaneous late-breaking presentation at the American College of Cardiology Annual Scientific Sessions entitled Cardiac Arrest During Long-Distance Running Races. Welcome, gentlemen.
Great to be with you.
Great to be with you.
So to frame the context of this paper, please tell us, what do we already know about the subject? Why is it important? And what do we still need to learn?
So maybe I'll just reflect briefly on the actual process that got us to this conversation today. It's actually a long one, and for me, a very personal one. As a young man, I had no intention of becoming a physician. I was thinking about one thing, and that was how fast I could run a marathon. At a very early age, lost a training partner, a very fit young man, a 2:20 marathoner, to sudden death, and that was a pivot point for me. It got me interested in medicine, got me interested in the concept of athletes with heart disease. In medical school, I actually started keeping a scrapbook of newspaper clippings of fatalities during distance running, and this became kind of a pet hobby of mine that I never thought would amount to much. Fast forward, as a junior faculty member at Harvard, a young man by the name of Jonathan Kim walked into my office and asked if I had any ideas for a project, and we started talking about sudden death during running. And that led to the very first RACER study, which was published in 2012, which really set the baseline around incidence and etiology of sudden death during distance running in the States. Shortly after that, I was in the capacity of medical director for the Boston Marathon and working with people really all over the world. We thought long and hard about what could be done to reduce this problem. And that included setting up educational courses for runners around CPR, making certain that defibrillators were adequate in number and placement on the race courses. And over the last decade, we had a hunch that things were really changing, that the races were becoming safer and the fatality rates were going down, but didn't know that. And so it was really an attempt to address that hunch, if you will, that led Jonathan and I to take a deep dive into RACER 2, which is where we are today.
Well, it's probably a rare case where such a personal story leads right into describing the methods of a particular research paper. But please tell us a bit about how this fairly unique study was conducted.
Well, thanks again. And we obviously modeled a lot of what we did for the first RACER 1 study. But to begin with, we had to ensure that we had the correct number of total race participants and the right number of races. There's been such an explosion over the last 13 years since we completed RACER 1. So I want to acknowledge both Running USA and Athlinks, who gave us a precise number of total race finishers, and then also the collaboration with USA Track and Field. And we did not have that partnership when we did RACER 1, but we were firmly able to confirm the total number of certified USATF marathons and half marathons included. And that number was 443. After that, then you have to identify the cases. And that's always where the rubber kind of hits the road whenever you do a study like this. And again, we leveraged a lot of what we did the first time, which was using public search engines, taking advantage of the fact that these are high profile cases. And we did that. But because of the intense growth within the industry of races overall, we knew we had to think of additional ways to try to corroborate cases, but also potentially identify ones that may not hit the newspapers. And what exists now that didn't exist in 2008-9 when we did this was an actual database of race directors. And we reached out to all 317 of these race directors for these 443 races. And we contacted about 70% of them to try to identify potentially other cases. And then lastly, USA Track and Field provided us insurance claims. So their injury claims that are submitted to their carrier, which included some cardiac arrests. And so we use all three of these sources to potentially identify cases. I think it's important to note that if we only utilize the media outlets, we actually we're able to identify the vast majority of these cases. So it really kind of highlights that Racer 1 was pretty successful with those methods many years ago now. And then in the end, it was calculating simple incidence proportions, having a denominator, having total number of cases to both calculate sudden cardiac arrest incidence and then the incidence of death, as well as etiologies. Those were all of the primary aims of the study. And then finally, were there new factors associated with survival?
All right. So what did you find?
So overall, over 29 million runners, compare that with 10.9 million from Racer 1. There were 176 total cases and there were 59 deaths. If you calculate the incidence proportion of sudden cardiac arrest, that's about 0.6 per 100,000 or 1 in 167,000 runners. Almost identical to what we found in Racer 1. What the key finding was that the incidence of death dramatically dropped by roughly 50%. So that was about 1 in 500,000 or 0.2 per 100,000. Again, that's about a 50% decrease. If you look at different demographics, we know that risk of cardiac arrest is higher if you're a man, if you're participating at the marathon distance. And if you look at the highest risk demographic, which are men who run marathons, they remain the highest risk demographic. But overall, that number, that risk hasn't changed that much. It is important to acknowledge one of our secondary findings, which was that since 2020, and one of the features of the study was, again, taking into account the COVID-19 pandemic, and has that also affected some of these numbers, that risk has increased a little bit. The incidence of sudden cardiac arrest from 2020 to 2023 is about 0.8 per 100,000. So there has been a rise, for which we don't know exactly why, but certainly the trend is there. Additional primary finding was etiology. In Racer 1, hypertrophic cardiomyopathy was the most common cause. In Racer 2, the most common cause was actually coronary artery disease. And hypertrophic cardiomyopathy was not one of the top causes whatsoever. But what's really fascinating is that those who suffered a cardiac arrest from coronary artery disease, over 90% of these individuals actually survived. And when we were able to analyze the small number of individuals, or the smaller number of individuals who we were able to garner complete case profiles for, there were 36 of these individuals. What was interesting was that a shockable rhythm was a factor associated with survival. And in fact, all of these individuals, all 36 of these individuals actually received bystander CPR, which was one of the factors that was associated with survival in Racer 1. And in the 3 cases where there was no AED available, unfortunately, all those individuals died.
So an AED, just to make sure everyone is on the same page, is a automatic external defibrillator, something that is designed for lay people and members of the public who do not need to have any particular medical knowledge to identify and deliver a potentially life-saving shock for, in particular, very fast ventricular arrhythmias. What are the implications of these findings in your view?
First and foremost, I think the implications here really, they highlight the value of the scientific process in which an observation is made, a problem is defined, and then work done in the community to address that problem actually does make a difference. What I think Racer 2 does for us as it relates to this reduction in fatalities is it shows that the work that was done over the last 13 years has translated into less loss of life. And that's an incredibly gratifying thing for us as scientists, but for everyone that's involved in sports, and particularly the sport of distance running. I also think we have a sobering side of this story, and that is that although you were more likely to survive a cardiac arrest, we haven't seen a decline in the cardiac arrest event incidence. And so I think we've attacked kind of the downstream part of the problem, and that's what to do when someone arrests. But we still have work to do on the upstream, and that's thinking about how to prevent the arrest from happening in the first place. And a lot of this gets back to recognition of the fact that no amount of fitness, no amount of strength, no amount of prowess is protective against underlying cardiovascular disease completely. There's no such thing as immunity from heart disease if you have particular risk factors for coronary disease. So that is a message that's not necessarily new, but one that hopefully Racer 2 will again remind people of and help clinicians all over the world think about the concept of no one walking in the clinic being too fit to have a problem. And this is where we have an opportunity to continue to identify, risk stratify, and hopefully prevent further cardiac arrest from occurring.
And then as our listeners and readers absorb this important information, what limitations would you caution them to keep in mind?
I think Racer 2 had three primary limitations. The first was that while our case ascertainment was similar to Racer 1, it wasn't identical because we had these two additional resources, the race directors and the USA Track and Field claims. However, as a part of the analysis, one of the ways that we addressed this was through a sensitivity analysis where we actually looked at only the cases that were identified by media reports. And what we found was that the incidence of sudden cardiac arrest was actually pretty similar, certainly not different. And even more important, all of the deaths, every single one, were captured by media reports. So there were no deaths that we would not have uncovered through these other means. That's really important. The second limitation, which was also identical to Racer 1, actually, was that we used race finishing times as a surrogate for total participants. And that's just by nature of how Running USA and Athlinks work. So theoretically, we could have double, triple counted people, and therefore our incidence may be actually a bit of an underestimate. But again, this limitation was also present in Racer 1. And then lastly, we were able to identify etiologies in a little over half. Interestingly enough, that's the exact number that we captured in Racer 1. So the same limitation applied there as well. But you have to acknowledge the potential for selection bias because of that. We did look at the groups by age and by sex just to compare demographics, and they were actually similar between the cases where we identified etiology versus not. So it suggests there is similarity, but we acknowledge that limitation as well.
Dr. Baggish already nicely summarized some important implications. I'm curious how you think about the clinical impact and whether you would extend this beyond marathon racers, beyond highly fit athletes to our general clinics and the lay public, and what are the important next steps going to be?
I think although there's been evidence of success in racecourse medicine and management of cardiac arrest cases, it is still not perfect. What we hope will happen within the U.S., but probably more important globally, is that people will be reminded, particularly those that are charged with overseeing these races, they'll be reminded of the importance of training their runners and their staff in CPR and making certain that there's adequate AED availability and a plan for how to place them and use them and move them around the course. And this is something that we're working with many, many people around the world to continue to educate and disseminate. And so hopeful that this will set a precedent and there'll be better standardization there for certain.
I think one of the most critical findings of this, which is really, really interesting and important, is that if you look at our survival rate in Racer 2, which was essentially 70%, that's identical to what you see in other public facilities where there is a publicly accessible AED, whether it's a casino, an airport, a high school that has an EAP in it. So an emergency action plan are the steps taken whenever an acute cardiac event occurs. It begins with recognition of a cardiac arrest by individuals, which then leads to immediate CPR by individuals who are trained in CPR, and that's certainly what we try to promote, education, and then having an AED within immediate access to be able to use, particularly if there is a shockable rhythm advised. The EAP also has to be written, and it has to be posted for individuals to read and regularly reviewed, practiced, and revised. Now we're talking about a 13.1 or 26.2 mile course, extremely complex geographic footprints, as we comment in the paper about, and yet we have a survival rate, if you have a cardiac arrest, that's on par with that. So I think this is a really important message beyond your half marathon and marathon. If you're a race director and thinking about your race medicine coverage for 10Ks, 5Ks, being able to work with local resources, EMS resources, to be able to think about what you can do, it's pretty clear that you can actually have outcomes similar to the best outcomes that we see for out-of-hospital sudden cardiac arrest here in the United States. It's a really, really important message.
We've made a lot of progress, but still ways to go. So much important science yet to be done. So thank you to our guests, Drs. Jonathan Kim and Aaron Baggish, and congratulations on a important original contribution. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. A link to this manuscript can be found in the episode's show notes. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.